Good afternoon, magandang tanghali po, and welcome to the celebration of the International Thyroid Awareness Week 2021, brought to you by the Department of Health in partnership with Iodine Global Network, World Health Organization, and the different societies of the Philippine Thyroid Technical Working Group. I am Dr. Arnel Paupo from the Philippine Thyroid Association, and I will be your moderator for the third day of this week-long webinar series. We would like to acknowledge first the presence of our respectable speakers and participants from the different centers of health development, primary care facilities, and everyone who is watching our live streaming via Facebook and YouTube. Again, a pleasant afternoon to everyone. Today's session on day 3 will talk about the intricacies of iodine nutrition among pregnant women and how it affects the physical and mental development of the children they bear. We believe that women in their reproductive age, especially those who are still in their teenage years, should be well informed and adequately prepared for the many challenges pregnancy entails. For this, we count on our obstetrician gynecologists, midwives, and other healthcare providers to whom they can turn for advice. And hopefully, aside from the usual obstetrical needs of the expectant mothers, a good part of their advice will focus on the nutritional requirements during pregnancy, especially about the micronutrients like iodine, which has a huge impact on pregnancy outcomes, and particularly on the brain development of the children they bear. We should ensure that adequate iodine intake is equally emphasized when we talk about multivitamins, iron, and folic acid as we discuss the prenatal supplements the expectant mother may take. On this webinar, we will also discuss the evaluation of congenital hypothyroidism and the outcomes of this newborn screening program, and hopefully shed some light about testing those infants born at home and in the far-flung areas of our country. Are we able to screen most, if not all of them? We will discuss this today. And as we know, physical deformities in infants may be quite evident and easy to detect, but not mental affliction. It is in the first 1,000 days of life, from conception to 2 years of age, that the child's brain develops, as neurons are formed and the interconnections with each other is established. It is this most critical time, and beyond which, it is already out of our control. So why is iodine so important in this process of brain development? We will know why during this lecture, the lectures for today. So for today's sessions, it is very opportune that we again will be joined by colleagues from different countries in the Asia-Pacific region where iodine deficiency remains a problem. And before we proceed to the program proper, we would like to present the webinar guidelines to ensure that this virtual gathering will be enjoyable and productive. So first, kindly indicate your agency or organization after your name so that we can recognize you accordingly. Please keep your microphones mute during the lectures. Turn off your videos throughout the program to save on bandwidth and prevent unnecessary distractions. Reserve questions until the Q&A portion. You may use the raise hand function of Zoom to be acknowledged, and alternatively, you can type your questions in the chat box and indicate who among the speakers you are addressing your questions to. And lastly, stay present throughout the sessions and enjoy learning with our panel of experts. Now that the webinar guidelines have been presented, we are now ready to listen to our speakers. To officially commence, we would like to welcome our first speaker from the Philippine Society of Maternal Fetal Medicine. She serves as the training officer of the section of maternal fetal medicine in Cardinal Santos Medical Center and in the Department of OBGYN in Pasig City General Hospital. She is the section head of maternal fetal medicine in Victor R. Potenciano Medical Center and she's the current president of the Philippine Society of Maternal Fetal Medicine. Let us all welcome Dr. Carmela G. Madrigal D. as she presents to us the topic on looking beyond the usual obstetrical needs of pregnant women. Dr. D, the virtual floor is yours. You may now share your screen, ma'am.
Thank you, Dr. Pauco. So good afternoon, everyone. The task that I am given today is to look beyond the usual prenatal care that we know. So as thyroid disorders and its sequelae become more and more common among our pregnant population, it is prudent to explore and understand thyroid physiology in relation to pregnancy. So just like I mentioned, yes, the thyroid gland and its hormones can have a major impact on our mothers and their unborn fetus, especially if disorders arise. So to better understand abnormal thyroid function in pregnancy, we must recall the normal physiologic changes early in pregnancy. So during the first trimester, increased thyroid hormone
Excuse
production.
me, Dr. D, may I
Yes.
interrupt you? Your slides po are presented in the presenter's view.
Sorry,
Can you switch it such that the slides are bigger?
sorry, doctor.
Doon po sa slideshow. Ayan po. Thank you po.
Am I okay? Doctor, is this okay?
Now po naka-presenter's view siya ulit.
I'm sorry. Okay, I'm sorry. Yeah, let me figure it out. I have to do this here. Let me just figure it out. Okay, doctor, I'll just wait lang for a while.
Okay lang po, ma'am. Ma'am, try niyo po doon sa slideshow, doon na tab sa taas.
Opo.
Slideshow. Doon po sa, balik po tayo, ma'am. Opo.
Teka lang, nakaano ko sa itong bar. Yan.
Yan po, sa tabi ng animations, yan po.
Yeah.
Kindly click and then doon sa yung use presenter views, doon po sa automatic, paki-drop down po yan.
Primary monitor.
Yes po. Primary monitor, pakilagay po primary monitor.
Yes.
Then let's try po.
Is this working na?
Yes po.
Yeah, can I start again, doctor?
Yes, ma'am. Kindly start again po.
Okay, thank you. Am I okay? Can you see?
Bumabalik po siya sa presenter's view, ma'am. Perhaps we can just make this this panel bigger so that we can see the slides better po. Ayan po, ma'am. Okay po.
That's okay.
Yes, ma'am.
Okay. So good afternoon, everyone. The task that I'm given today is to look beyond the usual prenatal care as we know. As thyroid disorders are more common among the pregnant population. So it is prudent to explore and understand thyroid physiology in pregnancy. So just like I mentioned, yes, the thyroid gland and its hormones can have a major impact on our mothers and their unborn fetuses, especially when problems arise. So we have to go back first to the physiology of the thyroid. in the first trimester. So to better understand it. So during the first trimester, there's increased thyroid hormone production, which occurs as a result of many physiologic processes. So first, the influence of human chorionic gonadotropin, which has an intrinsic effect, TSH-like activity, leads to an increased thyroid hormone production with a resultant negative feedback on by causing the decrease in TSH. Secondly, increased estradiol and its altered hepatic clearance leads to increased thyroid binding globulin. So this increase also increases the circulating thyroid hormones. Lastly, the effect of transplacental passage of thyroid hormones from mother to the fetus, as well as the iodide loss, renal excretion of iodine from the kidneys results to a 20 to 40% increase in thyroid hormone requirement. So as an effect, after the first trimester, free thyroxine levels may fall to a level in the third trimester, which is even lower than the pre-pregnancy level. So these are the trimester-specific ranges for the thyroid hormones. These are the published reference ranges. So as you can see here, so as a guide, the American Thyroid Association and the American College of Obstetricians and Gynecologists published trimester-specific ranges for thyroid hormones and TSH levels. But locally, Patal and his colleagues concluded in their study that these trimester ranges among pregnant women are different from their non-pregnant counterparts. And the laboratory cutoffs are different also for the pregnant. That's why they've published reference ranges that should be used in our country. In that this is the one in the third column. So the thyroid disturbances are common during the reproductive years of the lives of the women. So autoimmunity and altered iodine status together account for a high proportion of the abnormalities. So several studies have demonstrated a strong relationship between thyroid immunity and hormone disturbances and infertility, miscarriage, and in pregnancy and postpartum. So optimal thyroid function is essential during these stages of life. However, it is most significant during gestation when the fetus is reliant on the transplacental supply of thyroxine, which is important for normal neurological development, as we know. So in pregnancy, other adverse maternal and fetal outcomes are also significantly correlated, specifically for subclinical hypothyroidism to fetal deaths, placental abruption, and premature delivery, and for subclinical hyperthyroidism to gestational hypertension. So according to the 2017 American Thyroid Association and the 2020 American College of Obstetricians and Gynecologists Practice Bulletin Guidelines, universal screening is not recommended for thyroid disease. So mainly because the identification and treatment of subclinical hypothyroidism has not been shown to improve pregnancy and outcomes and neurocognitive function on their offsprings. So what we do is targeted screening of those who are at high risk for developing thyroid disorders. So who are the patients or women who are high risk or who should be screened? So these are women with a history of hyperthyroid or hypothyroid disease, postpartum thyroiditis or thyroid lobectomy, women who have a family history of thyroid disease, women with presence of goiter, those with thyroid antibodies when known, with those with signs and symptoms suggestive of thyroid disease or thyroid under or overfunction, those with type 1 diabetes mellitus and other autoimmune disorders, those with infertility or failed pregnancies, women who have therapeutic head or neck irradiation, and those who have history of miscarriage or preterm delivery. So when screening, this is the algorithm by the American Thyroid Association. So we follow this one starting off with the TSH screening, as you can see on top. So what will guide us is the first trimester specific ranges that I showed you earlier. So I will not go through the algorithm anymore one by one, but it's important to take note that the cutoff for TSH is 2.5 milliunits per liter. Anything above this value is considered abnormal, and further evaluation needs to be done. So, of course, in areas where resources are limited, where iodine deficiency is endemic, obstetricians should be keen on the signs and symptoms of thyroid dysfunction. We should be aware, however, that most of these may also be present in normal pregnancies. So a thorough evaluation and history should be done, and as well as a physical examination to make sure that this is not overlooked. So ACOG has listed a few of these that are suggestive of hyperthyroidism in pregnancy. So these are the following. So nervousness, tremors, tachycardia, palpitations, frequent stools, excessive sweating, heat intolerance, weight loss, insomnia, and palpitations, and a palpable neck mass. So hypothyroidism, on the other hand, may present with fatigue, constipation, cold intolerance, muscle cramps, weight gain, edema, dry skin, and hair loss. So after thorough history, taking part and parcel is a complete prenatal checkup, and physical examination should include the palpation of the thyroid glands. So I'm sure a lot of us obstetricians overlook this or we're guilty of not performing this. So during palpation, we should check for the thyroid gland and if there's enlargement or the presence of nodules or masses. If so, a referral to our friendly endocrinologist or ENT should be done. So this is a table that shows some of the adverse outcomes for mother and baby. So these result from thyroid disorders when they are left untreated or uncontrolled. Suffice to say, it has a profound effect on both the mother and the fetus. So emphasis on early diagnosis and intervention is of utmost importance. So moving on, how should we counsel our patients who have been diagnosed with thyroid disease? So preconception counseling, which is very important now in a lot of diseases among our mothers before they get pregnant. We do this already. So preconception counseling is very important. So women with hypothyroidism should be counseled about the importance of achieving the euthyroid state before conception because of the risk of decreased fertility and miscarriage. So euthyroid women on medications should continue to take levothyroxine and should adjust their doses as the thyroxine levels or the thyroxine with consultation, of course, with their endocrinologist, because they need to the thyroxine dose may need to be increased by 30 to 50% in early pregnancy. That's why levothyroxine should not be discontinued. So for women who are hyperthyroid, they should discuss the available treatments and the potential adverse effects on future pregnancies and in the outcomes of their babies, such as congenital abnormalities and neonatal hypothyroidism, which are caused by transplacental transfer of antithyroid hormones. So although radioactive iodine ablation is not associated with long-term consequences on fertility or pregnancy outcomes, it is advisable to wait 6 months after therapeutic dose is administered before attempting pregnancy. So also part of our counseling is to educate the women about the importance of iodine supplementation before and during pregnancy. So based on the latest studies, the Philippines is considered not iodine deficient anymore, but with the exception of the pregnant population. So the more for us obstetricians to be keen on our pregnant patients for these thyroid disorders. So dietary sources of iodine may come from seafood, such as crabs, mussels, certain kinds of fish, and also snails. According to guidelines, the recommended iodine intake should be 150 milligrams per day in women of childbearing age. And this should be increased to 250 milligrams per day in women who are pregnant or breastfeeding. But daily iodine intake should not exceed 500 milligrams per day. So for my take-home messages, thyroid disturbances are very common in women during the reproductive years of their lives. So suboptimal iodine status affects a large proportion of the world's population, and pregnancy severely depletes body iron stores. So both thyrotoxicosis and hypothyroidism are associated with adverse pregnancy outcomes. And current guidelines recommend targeted screening of women at high risk. So it's very important to identify these high-risk women. So appropriate management results in improved outcomes, demonstrating the importance of proper diagnosis and treatment. So I hope I was able to enlighten all of you on the importance of thyroid, identifying the risk factors, identify the women at risk, palpating the thyroid, eliciting a very thorough history in your patients so that we will not overlook thyroid disease in pregnancy, and we even do preconceptional counseling, which is important, so that they will not have the consequences of thyroid disease in their pre-pregnancy years. So thank you very much, and good day to all of you.
Thank you, Dr. Carmela Madrigal-D, for your presentation.
Thank you, Doctor.
It was enlightening, and thank you for guiding us in knowing who among our women in the reproductive age we should look out for possible thyroid disorders and how to detect and counsel them appropriately, highlighting the importance of adequate iodine intake for better pregnancy outcomes. Thank you, ma'am. Now, we are very fortunate to have with us another distinguished speaker. She is an assistant professor at the De La Salle Medical and Health Sciences Institute, College of Medicine, a consultant and newborn screening coordinator at the De La Salle University Medical Center, Department of Pediatrics in Dasmariñas, Cavite. And currently, she is the president of the Philippine Society of Pediatric Metabolism and Endocrinology, or the PSPME. Let us all welcome Dr. Cynthia G. Feliciano to discuss with us newborn screening for the congenital hypothyroidism. Have we picked them up? Take it away, Dr. D.
Good day, everyone. Congenital hypothyroidism, or deficient production of thyroid hormone manifesting at birth, is the commonest treatable cause of mental impairment and growth retardation. It is almost always overlooked in the newborn, because most of them born with this disorder have normal appearance and no detectable physical signs. Hence, an effective screening tool is necessary for early detection and prompt management of this condition to avoid serious complications. At the end of my 15-minute talk, it is my objective to answer if the Philippine newborn screening has actually picked up our cases of congenital hypothyroidism. For better understanding, let me briefly refresh you first what is the disorder all about. The thyroid is regulated by thyroid-stimulating hormone, or TSH, secreted in the pituitary, activating adenylate cyclase in the thyroid. Congenital hypothyroidism is a disorder of deficient production of thyroid hormone manifesting at birth, either caused by a defect in the thyroid gland itself or the pituitary gland regulating it. Congenital hypothyroidism may be termed primary or peripheral in etiology if there is a defect within the thyroid gland itself, resulting to inadequate thyroid hormone production. When this happens, the negative feedback inhibition to the pituitary is lost, resulting to increased levels of TSH production. It can also be secondary or central in etiology if the defect lies in the pituitary, having a reduced TSH secretion that would limit stimulation to the thyroid gland, leading to a decreased thyroid hormone production. Central hypothyroidism can occur in any of the conditions associated with the developmental defects of the pituitary or the hypothalamus. On the other hand, primary CH is caused by structural or some form of thyroid dysgenesis, accounting for 80 to 85% of cases. It can be aplastic, wherein no remnants of thyroid tissue can be found, even in sensitive radionuclide scans. In the other 66% of infants, there may be rudiments of thyroid tissue in its normal position but hypoplastic, or in an ectopic location anywhere from the base of the tongue. Primary CH is usually sporadic and permanent. Another cause of primary CH is a variety of defects in the biosynthesis of thyroid hormone, accounting for 15% of cases. These defects are transmitted in an autosomal recessive manner, and the goiter is almost always present. The rest of the conditions, including iodine deficiency, comprise the least common causes. Most clinicians nowadays rely on newborn screening for the diagnosis of congenital hypothyroidism. Newborn screening is a public health strategy aimed at early detection and management of several congenital disorders, including CH, which, if left untreated, may lead to mental retardation and/or death. Most countries, including the Philippines, utilize TSH alone and was shown to be more specific in the diagnosis of CH. Although more sensitive, screening by T4 and TSH together is not cost-effective. Therefore, mostly TSH and rarely T4 screening is used around the world. T4 screening was more sensitive in detecting newborns with rare hypothalamic pituitary hypothyroidism, but less specific with a high frequency of false positives, mainly in low birth weight and premature babies. Elevation of TSH beyond the set cutoffs signifies possible congenital hypothyroidism. Once noted, A confirmatory test should be done by measuring both FT4 and TSH soonest possible time. Since it is only TSH elevation that is being reported in NBS, it can only detect primary CH, but not those of secondary or central in etiology. Based from the Philippine Newborn Screening Reference Center, as of December 2019, 5,079 babies have been confirmed with CH out of the 13,798,874 screened, giving a prevalence of 1 per 2,716. This annual prevalence has not changed significantly since 2004, with a range of 1 per 2,600 to 1 per 2,800, regardless of the national coverage. It is also within reported prevalence in other countries, which ranges from 1 per 2,000 to 1 per 4,000 infants screened. It is third most prevalent disorder among those screened, following G6PD deficiency and hemoglobinopathies. This slide shows the national coverage of NBS from the time it was introduced in the country in 1996, then formally operating in 1997 up to last year, with a national coverage of 80.4% in 2020. Note that the coverage started to significantly increase in 2006 and annually thereafter. This was the time when NBS was included in the Philippine Health Insurance Newborn Package, covering 90% of the NBS fee. The blue bars indicate the coverage for the basic NBS package, comprising of 6 disorders including CH. The yellow bars, on the other hand, indicate the coverage for the expanded NBS package, comprising the additional 22 disorders to a total of 28 disorders screened starting 2015 when it was first offered. In the past 3 years prior 2020, national coverage has already been maintained above 91%. However, it was not sustained but actually declined by around 12% last year, 2020, when the COVID pandemic hit the globe, limiting movement and access of the people to the healthcare system. Looking at the graph on the NBS coverage per region for the past 2 years, there was a decrease in coverage in all of the regions of the country last 2020 compared to that of 2019, most probably due to the COVID crisis. The lower than the national target coverage of 100% is being pulled down by the low coverage in ARMM. For regions exceeding 100% coverage, such as NCR and CAR, it may be attributed to the additional infants delivered and screened in the region who are not their usual residents. These are the babies born outside their usual place of residence, perhaps in search for better healthcare facilities and social services in the receiving region. So going back to the query, have we really picked up CH from NBS? To answer this, we should be digging into 2 different perspectives. First is the screening test, which detects the disorder itself, and second is the extent of coverage among the population at risk. For the screening test, TSH has been reported to have high sensitivity and specificity at 97.5% and 99% respectively. In detecting infants with congenital hypothyroidism. As to the national coverage, although it has significantly improved through the years since NBS started in operation, the Philippines is still far below the target of 100%. To emphasize using numbers, if the national coverage of NBS last year is only 80.4% based from the total live births of 1,700,618, we were not able to screen 333,321 newborns. With a CH prevalence of 1 per 2,716, it follows that in 2020, around 123 babies with CH were not detected at birth. This boils down to the importance of realizing the 100% national coverage of our NBS program. Despite the development of accurate test programs, approximately 5% of CH cases may still be missed in any screening program for the following reasons: failure of sample collection, unsatisfactory samples, misinterpretation of samples, unsatisfactory recalls, including subclinical conditions and central cause of CH. Since there is still a significant percentage of babies who escape newborn screening or laboratory error, physicians must be vigilant in picking up early signs and symptoms of CH as listed. Clinicians should not rely entirely on newborn screening for its diagnosis. It should be remembered that most infants with CH are asymptomatic at birth, even if there is complete agenesis or absence of the thyroid gland being attributed to partial transplacental passage of maternal T4. It can be suspected and the diagnosis established during the early weeks of life if the initial red flag signs are recognized. Because symptoms appear gradually, the clinical diagnosis is often delayed. If congenital hypothyroidism goes undetected and untreated, the manifestations progress, and by 3 to 6 months of age, the clinical picture is fully developed, as seen in this slide. In summary, untreated congenital hypothyroidism would result in severe mental impairment and growth retardation. With newborn screening program in place, its early detection leading to prompt management has saved these babies from having the deleterious complications, allowing them to live a normal life. Achieving a 100% national coverage would ensure avoidance of missing out infants with the disorder. For infants who escape NBS or laboratory error, clinicians must maintain vigilance in recognizing the early red flag signs of CH for prompt diagnosis and treatment. These are my references. And for any questions or clarifications, you may email me at this address. With that, thank you for your attention and good afternoon.
Thank you, Dr. Feliciano. It is encouraging to know that we have a screening test with a high sensitivity and specificity, and that we are working on achieving 100% national coverage for newborn screening. And since no test is perfectly accurate, as you have mentioned, it is important that our listeners be able to recognize those red flag signs so we can manage our patients promptly. Thank you, Dr. Feliciano.
Thank you,
And
Dr.
now that we have discussed the importance of newborn screening for congenital hypothyroidism, let us now unravel the correlation between the mother's iodine status and how her baby's brain is developed. Our speaker has postdoctoral and clinical fellowship degrees at the Erasmus University Medical Center in Rotterdam, the Netherlands. He also has a PhD in thyroidology of pregnancy and is a co-founder of the Consortium on Thyroid and Pregnancy. Let us all warmly welcome Dr. Tim Korevar to present to us the clinical studies on the association of maternal iodine status, thyroid function, and fetal brain development.
Hello, everyone. My name is Tim Korevar. I'm from the Erasmus University Medical Center in Rotterdam and in the Netherlands. And it is my absolute privilege to provide this talk on iodine, thyroid hormone, and brain development of the child. Unfortunately, due to the large time difference, I will not be able to answer any questions live, but please feel free to email me if you have any questions. The email address will be displayed in my slides. Again, thanks very much for the invitation. And I'll now just pull up my slides. So I will be mainly discussing the clinical studies on these associations because I saw on your excellent program that a multitude of other topics have already been covered. So I'll first provide a brief introduction, then talk about the link of iodine and offspring neurocognitive development and what kind of clinical studies we have on this topic. Then I'll talk a little bit about the working mechanism and the link of iodine status and thyroid function in pregnant women. And then finally, I'll end up with providing a brief update on clinical studies around maternal thyroid function and offspring neurocognitive development. So we have known for quite a long time that iodine deficiency is associated with considerably impaired neurocognitive development of the fetus. And we have known for a very long time, for example, that cretinism is associated with severe hypothyroidism caused by iodine deficiency. But also from 1997, this very interesting randomized controlled trial performed in Indonesia already showed massive results and positive effects of iodine supplementation versus placebo. So in this randomized trial, 6 to 10-week-old infants were randomized to receive iodized oil or placebo. And they actually found that the mortality in the iodine depletion group was only half that of the placebo group, indicating that, not only for early brain development, but for development in general, iodine, even in the early postpartum period, is very important. Now, what's important to realize is that actually all of these kind of trials looking at severe iodine deficiency have all been done, and we all know the results. So in fact, all of those studies were the low-hanging fruit. And the studies that we now have to do and that are now being performed worldwide shouldn't be considered as the low-hanging fruit anymore. And therefore, it doesn't seem logical to also expect such large effects in the studies that we are currently doing of mild iodine deficiency, for example, as the ones that we have seen for severe iodine deficiency. So just to give you some examples of studies that have been published in the last decade or so, The most famous one, I think the most well-known, is this one from the ALSPEC study by Sarah Bath and Margaret Raymond, in which in the UK, over 1,000 women and their children were followed. And in those women in early pregnancy, a single urinary iodine measurement was performed. And in that population, there was mild to moderate iodine deficiency present based on the median urinary iodine concentration of about 90 micrograms per liter. And as you can see in the table here, and also on the right side of my slide in the graph, what's interesting is that the lower the urinary iodine excretion was, the lower the verbal IQ of the child, with a difference that ranges anywhere between 4 to 5 points lower IQ between these groups. Now, although this study is very often cited in a lot of papers in this field, it's very important to realize that actually there also are quite some negative data and studies that didn't find similar results. So in the Generation R cohort, which is a cohort in which I have been working, although I was not involved in this particular paper, in the iodine sufficient population of the Netherlands, in 1,500 women and their children, there actually wasn't any relationship between urinary iodine and verbal IQ or language development in the child, implicating that perhaps only in populations that are mildly to moderately iodine deficient, such an association could be present, or that the ALSPEC study was a one-off study. Similarly, in this study from the INMA cohort, which is a prospective birth cohort from Spain, multiple sites in Spain, also in almost 1,300 pregnant women and their children, there was no association between urinary iodine content and child IQ. And in this study, they also looked at a small proportion of women in which iodine fortification was done via multivitamin supplements, for example. And also in those women, there was no association with IQ of the child later onwards. So you can say one big study from ALSPAC showed it, but then actually the other cohorts that came after that weren't really pointing in the same direction as ALSPAC. But we wanted to investigate in one of our studies whether the mild to moderate iodine deficiency in a population could be predictive of the results of ALSPAC, and perhaps there weren't enough women in INMA or in Generation R that had iodine deficiency, mild iodine deficiency. So what we actually were able to do in this paper by Deborah Levy from our group was we combined these prospective cohort studies, the raw data, into one large data set and reanalyzed. And what we then found when we combined these three cohorts with these different states of iodine deficiency on the population level, and we found a very clear, actually dose-dependent association of the urinary iodine content with IQ of the child. Clearly showing here that in these prospective cohort studies, at least, lower urinary iodine concentrations are associated with lower child IQ. One very interesting thing that Dr. Levy was also able to do in these analyses is to actually stratify it by the time at which the iodine content in the urine was assessed. Because we know that probably in early pregnancy, the dependency on maternal thyroid hormones and on maternal iodine status is much more important for brain development than during later stages of pregnancy. Also because in humans, brain development starts at around 5th week of pregnancy already. And what she actually found when you look at this data is that this association of lower iodine concentrations with child IQ is actually mostly prominent in the first trimester, but after the first trimester, so towards 14 weeks or over 14 weeks, as you can see in the middle and right graphs here, this association no longer seems to be present, indicating that the relevance of iodine deficiency could be much more prominent for early pregnancy than for later stages of pregnancy, although further studies will of course be needed to replicate these data. Some other studies have come out in the meanwhile. So end of 2019, the Norwegians did some analysis in their MOBA cohort, showing again that, for example, the risk of internalizing and externalizing abnormal behavior is higher in lower urinary iodine or iodine intake assessments. And also, as you can see here, certain reading tests and reading skills also were different in the children from women with lower iodine status. So this really keeps on being an ongoing field, and we're learning more about different outcomes and also different populations and how these associations are present there. By far, the most important study in this field was the study by the group of Michael Zimmerman, published a few years ago, because this was one of the best, if not the best, current randomized trial out there. This was a randomized trial in which about 150 women were randomized to receive iodine supplementation, and 150 were in the placebo group. And in the supplementation group, you can very clearly see that in women with mild to moderate iodine deficiency that were included in this trial, on the left, the urinary iodine content increased considerably because this is the group shown in red versus the placebo group in blue. But what you can also see, unfortunately, is that even though the blue group actually started at mild to moderate iodine deficiency, there was also a normalization of their iodine availability and their urinary iodine content, despite the fact that they only got a placebo, which makes the interpretation of these results very difficult. And what you can see in the table is that when they assessed the IQ scores in different ways during follow-up, when the children were about 5 years of age, there wasn't actually any difference between the iodine supplemented group and the placebo group. So where do we now go with this field? I think there's still probably a lot of interesting studies left that we can discuss, and also the role of prospective cohort studies is still very important to inform what kind of randomized controlled trials we really need to do. Because even though this large trial was a negative trial, there are important limitations, and we may learn from those limitations and new data from prospective cohorts to change the way that we set up trials to really investigate whether iodine supplementation in pregnancy or perhaps before pregnancy can be beneficial for fetal brain development. So here's a study that was recently published from our group. In Generation R, about 1,000 children, we also had MRI data available at the age of 10 years. And MRI scans are, of course, a very objective way of quantifying differences in brain morphology. And this is something that has not yet been published on in this particular field. And although this was quite a small study, and I don't mean small because we only had 1,000 participants, but especially small because the effects are relatively small that we would expect. So we really need large numbers to show statistically significant results. Here you can see the association overall that we found between the total gray matter volume in the brain of the child and the urinary iodine to creatinine ratio. And what you can very clearly see again is that a lower urinary iodine concentration was associated with a lower gray matter in the brain, but that there also seems to be this optimal point around 150 to maybe 300 urinary iodine to creatinine ratio. Whereas on the left side and right side of this graph, the gray matter seems to be a bit lower. Now, we didn't have statistical power, like I alluded to a little bit before, but really these data require further follow-up studies to see where we can extract what could be the optimal range that we can strive for in future trials. A study that I am very, very interested by is this study by Robinson et al., which was published in 2018, because this has been the only prospective cohort study in which actually preconception iodine status was assessed. And then throughout pregnancy, they followed up these children and also during later life. And then they tested the IQ at the age of 6 to 7 years. And although, again, this was quite a small study with only 650 participants, they did find a statistically significant difference here because the effects were very large. So what you can see here on the left side is the association of these different iodine to creatinine ratio groups with offspring IQ. And offspring IQ is put here into SD scores. And an SD score of about 0.5, which is the difference with the control group in the graph here, as you can see, is about 7.5 IQ points. So this is a massive effect. And what they found is that women who had an iodine to creatinine ratio in the urine of lower than 50 micrograms per gram, those children had an up to 7.5 points lower mean IQ score, implicating that perhaps because early pregnancy is such a vulnerable period, the preconception urinary status of the mother, urinary iodine status of the mother, is very important and is a much better marker of what's going on in early pregnancy. But again, further replication here is needed. Now, one thing that I always wonder about is if iodine is important for brain development, what is the working mechanism? And here you can see an image that shows iodine, radioactive iodine imaging. And the only place that typically lights up on these scans in the brain is the choroid plexus. But you can see the brain itself doesn't necessarily very actively take up iodine. So what is the working mechanism between gestational iodine status of the mother and brain development of the child? And most likely, and what most people find, at least biologically, very plausible, is that this association is actually mediated via changes in thyroid function of the mother. So then the question is, what is the actual evidence for an association of maternal iodine status and thyroid function? One of the first papers and one of the largest to date is this Chinese study published in 2014, looking at different iodine concentration, urinary iodine concentration groups, and, for example, the risk of subclinical hypothyroidism or isolated hypothyroxanemia. And what was very interesting already about this study is that it was the first to show that actually women with high urinary iodine concentrations had a higher risk of subclinical hypothyroidism and isolated hypothyroxanemia. So actually going the other way than we would have expected the association to be, and implicating that perhaps too much iodine also could have negative consequences for thyroid health and thyroid function of the mother. They also looked at TSH concentrations and 3T4, as you can see in the bottom of my slide. And here again, they found that high iodine concentrations in the urine were actually associated with higher TSH and lower 3T4. So very interesting data still. In this study from, again, the Norwegian group, where they also looked at the association of the urinary iodine concentration or iodine intake estimated from food frequency questionnaires, they also found very interesting results. Again, they showed when you look at the plasma 3T4 and the plasma 3T3, is that higher iodine was associated with lower free T4 and lower free T3 concentrations. Again, the opposite direction of what you would perhaps expect. And they also found a large difference between how we estimate what the iodine availability in the mother is. So when you measure it in the urine, like most studies have done, this association is actually there. But when you measure it using food frequency questionnaires, there's actually no association with thyroid function, implicating that the urinary iodine content is a much better proxy for trying to establish what iodine availability, what the iodine availability status is of the mother during pregnancy. In the study by Levy et al. Of the 3 prospective birth cohorts of ALSPAC and Generation R and INMA that I discussed some slides ago, we also looked at the association of these urinary iodine to creatinine ratios and thyroid function. And again, we actually found that higher urinary to creatinine ratios associated with higher TSH, but we didn't find many differences with regards to the T3 or the free T4 concentrations. So this link isn't very clear. One interesting study that was performed was a randomized controlled trial in which 100 microgram of iodine was supplemented in women with iodine deficiency based on changes in their thyroid function. So Daniel Glinouer in 1995 in this population investigated this. And what you can see is this green line and this red line here, representing by the green line is the group of women who had iodine supplementation, and the red line who was the control group. You can see their urinary iodine went up as expected with iodine supplementation, but there was only a slight difference in the free T4, only apparent in late pregnancy, whereas there was quite some relevant suppression of this increase in TSH that was seen in the placebo group when you looked at the green group, so the supplementation group. But now going to a more timely trial, again by the group of Dr. Zimmerman, what they found again was that in the iodine supplementation group, I've shown this data before, the urinary iodine excretion goes up, but when you look at the difference between these two groups in the change in the free T4 concentration that I've shown here, there was a slight difference in the trajectory throughout pregnancy, but you can actually see that in the iodine supplementation group, the free T4 goes down a little bit more than in the placebo group, again implicating that iodine supplementation could actually have non-beneficial effects on thyroid function. And similar results were found when they looked at the free T4 concentrations in all trimesters, or when they looked at the risk of hypothyroxemia, for example. So let's talk about thyroid hormone of the mother and brain development of the child and what we really know there. Also there, we have a lot of prospective cohort studies that can actually inform randomized controlled trials. And I really want to make that point again about the importance of prospective studies, not only in the iodine field, but also in the thyroid field, to inform randomized controlled trials. Many of you will probably know this very important randomized controlled trial performed in the UK and Italy, also known as the CATS trial, in which women with mild thyroid function test abnormalities such as subclinical hypothyroidism and hypothyroxemia were treated either with 150 micrograms of levothyroxine, so a very high dose, or they were not treated and belonged in the placebo group. And when they looked at the child's IQ at the age of 5 years, there actually wasn't a difference between these two groups, implicating that actually for mild thyroid function test abnormalities, levothyroxine treatment doesn't improve the brain development of the child. Some studies from our group then came out, again implicating that perhaps there could also be negative consequences of high thyroid function in pregnancy on brain development of the child. So similar to how perhaps high iodine intake could negatively impact thyroid function, or perhaps even child brain development, although the data for that is not very clear yet, in all honesty. And what we found in those studies, if you look on the left, is that there is actually this inverted U-shaped association of maternal TSH and free T4 for child IQ, but also for the brain MRI outcomes. So this implicates that both too low and too high thyroid function of the mother is associated with suboptimal brain development of the child. So those data then actually prompted the CATS trial investigators to redo some analyses and investigate if there were any negative consequences in the group of women that were treated and had a very high thyroid function because of that treatment. And what they actually found is that in the women who had a high free T4 in that treatment group, those children had a much higher risk of ADHD and also much more behavioral problems, indicating again that perhaps in this trial, a subset of women was overtreated and there were some negative consequences of that overtreatment. So this has actually been translated into clinical guidelines in which we want to strive actually when we start treatment for the scenario on the left part of my slide, where we want to go for the optimal treatment scenario in which a woman with low thyroid function is treated to the middle of the reference range. And we want to prevent the right part of this slide, which is the overtreatment scenario, which is when a woman comes in with low thyroid function and we treat her with a too high dose of levothyroxine, and we actually bypass the optimal point in this curve, and the net benefits of our treatment are much less than they could potentially be. For this reason, for example, in women who have subclinical hypothyroidism or TPO antibody positivity with the TSH above 4, we no longer start with a full dose of levothyroxine, but we start with a low dose of, for example, 50 micrograms a day of levothyroxine to make sure that we don't overtreat women during pregnancy when we treat them with levothyroxine. Another very relevant example of how prospective studies can actually inform future randomized controlled trials on iodine and thyroid supplementation in pregnancy is this very well-known trial performed by the Americans, the NIH. This trial was slightly different than the CATS trial because here they treated women with a lower dose of levothyroxine, so the risk of overtreatment probably wasn't there. Women with subclinical hypothyroidism during pregnancy were treated with 100 micrograms of levothyroxine, and women with hypothyroxemia with 50 micrograms of levothyroxine. And here you can see the results. This study was powered to detect a statistically significant difference of 5 IQ points. But actually what they found was that levothyroxine increases the child's IQ by about 3 points on average. But unfortunately, even though this 3 points was to be expected, because that's what all the observational studies have actually shown to date, this randomized controlled trial was only able to detect a 5-point IQ difference. And as you can extract from the p-values on my slide, these differences in IQ between the groups were not deemed to be statistically significant. And here you can see how large a study should actually be based on the data that we have now to find a statistically significant 3-point IQ difference. So this is shown by the blue dotted line, and as soon as the red or green line is below the blue dotted line, that's when there is enough statistical power to show this 3-point difference to be statistically significant. And neither of these trials cross any of those colored lines below the blue dotted line, showing graphically that they were actually not statistically powered to show the difference that we would expect based on observational studies. So also in this respect, observational studies can really help us how to design trials and make power calculations. In this study, Toya Janse, a very good master student from our group, was able to look in Generation R at a new subset of children who underwent MRI scans. And this time we didn't have 650 children like in the last study that I showed you, but we actually had almost 2,000 children who underwent MRI scans at the age of 10 years. Now, what we were able to do in this study is replicate the results that I showed you for 3T4 in the previous study. And we also found this association there for TSH. But the most interesting thing about this study is that similar to the data that I showed you from Deborah Levy on iodine and differences in the association with IQ, depending on the time of pregnancy when it was measured, we also found something similar in Generation R here. So here you can see the association of TSH with the cortex volume of the brain, where most of the gray matter is situated. And again, at 8 weeks and 10 weeks and 12 weeks, as you can see, we find that both too low and too high thyroid function is associated with a lower cortex volume of the brain. But once you get to 14 weeks, 16 weeks, or 18 weeks, this association is no longer present, implicating again that especially in early pregnancy, thyroid function is important for brain development. And when you now look at the timing at which treatment was started in the randomized controlled trials that we have so far, you can see that the median start of levothyroxine treatment in the NIH trials was about 17 to 18 weeks, and the median for the CATS trials, in which women were probably overtreated, this was about 13 weeks. But when we go back to the physiology of thyroid function and human brain development in utero, we know that neurogenesis starts in the 5th week of pregnancy, but the fetal thyroid is not fully functional until about 18 weeks of pregnancy. So for all of these important brain developmental processes that are regulated by thyroid hormone and that start in the 5th week of pregnancy, such as the neuronal cell proliferation, migration, and differentiation, the thyroid hormone availability in the fetal brain is dependent between week 5 and week 15 to 18 on the placental transfer of maternal thyroid hormone and therefore on maternal thyroid function. So when you start levothyroxine supplementation, only at the end of this physiological window, 17 to 18 weeks, it is logical that you don't see the effects that you actually would have expected when you look at child IQ. So again, this is an example of how cohort studies and prospective cohort studies can inform, in this case, when to start treatment or how to design trials in general. So what have we learned from these thyroid studies and what can you implement in your daily practice from this? It's probably 2 things. The first thing is don't use a cannon to shoot a mild thyroid function test abnormalities such as subclinical hypothyroidism. We don't know whether treatment is beneficial, but we probably now do know that we shouldn't treat with a high dose of levothyroxine, and probably it's best to start with 50 micrograms a day. And the second thing is probably that if we start levothyroxine treatment at 18 weeks of pregnancy, this is probably too late in pregnancy to expect the maximum benefit, if any at all. And those are the main things that we really know for sure from randomized trials. But there's also a lot of things still to know. So think about the risk of overtreatment and also think about this potential window of opportunity. And I think the whole community should also try to use this data so that when there is going to be funding for a randomized trial in the future, we take this into account and we design that trial in a way that we take all of these things into account. So to conclude, I think there is a good biological rationale why iodine status of the mother and good optimal thyroid function of the mother are actually important for fetal brain development. And, observational studies, when you combine them and when you look at them separately, if they assess different outcomes, they also mostly support these concepts. And we learn from them that, especially in early pregnancy or maybe even preconception when it comes to iodine status, is very important. But the randomized controlled trials aren't designed in a way that we can really say that iodine supplementation or levothyroxine supplementation is truly beneficial. Also, I think we do have some evidence now that too much of a good thing is probably also not good. We see that too high iodine intake is associated with lower thyroid function, and we see that too high thyroid function is also associated with lower child IQ. Now, if a woman is hyperthyroid because of her HCG effect in pregnancy, we shouldn't treat women with anti-thyroid drugs, because anti-thyroid drugs, of course, increase the risk of fetal birth defects. So the negative consequences and the risks of those treatments do not weigh up against the potential risk of hyperthyroidism caused by HCG in pregnancy. However, when we treat a woman with levothyroxine, we can control what the 3 to 4 concentrations are. And we should really strive for the middle of the reference range. And as I said, future studies are really needed to also look at, not only the relevance of iodine status or the relevance of thyroid dysfunction in pregnancy, but also at the combined effect of thyroid dysfunction caused by iodine deficiency. Because I think, based on earlier data in cretinism caused by iodine deficiency with hypothyroidism, that the combination of these two deficiencies perhaps has much more clinical consequences than them separately. So here are many people who I'd like to thank. I would also like to draw your attention to the Consortium on Thyroid and Pregnancy, which I'm the coordinator of. We also have a website, which is www.consortiumthyroidandpregnancy.org, where we explain all the meta-analysis that we do. We're actively collecting data and seeking for collaborators with data on thyroid function in pregnancy to large meta-analysis studies. My email address and my Twitter account is also on this slide. If you have any questions, please feel free to contact me. And thank you very much for your attention. And I hope that you enjoy the rest of the conference.
Thank you very much. Thank you very much, Dr. Tim Corevar, for showing us the association between the maternal iodine levels and the thyroid function and the neurocognitive development of their children, especially in preconception and early pregnancy. It is also important to know that too much of iodine or thyroid hormone supplementation is also something that we should avoid. And there is an optimal range that should be maintained for appropriate fetal development. And as Dr. Corevar has mentioned, due to the time difference between the Philippines and the Netherlands, Dr. Corevar will not be able to join us later during the open forum. So kindly just take note of his email address and Twitter account where you can send your clarifications and questions later. And now for our last speaker, he is no less than the president of the Child Neurology Society Philippines Incorporated. He is also the current chair for training of the Department of Pediatrics and head of the Epilepsy Monitoring Center of the Region 1 Medical Center. Let us all give a warm virtual applause to Dr. Adolfo Solis to present to us the neurodevelopmental outcomes in iodine deficiency. Dr. Solis, the virtual floor is yours. You may now share your slides, sir.
Thank you very much, Doctor. Good day, everyone. Can everybody see my slides?
Yes, we can see them, doctor.
Okay, thank you.
Thank
So,
you.
good day, everyone. I will be now talking about the neurodevelopmental outcomes in iodine deficiency. So, as an introduction, we all know that iodine is one of the important micronutrients. It's actually specifically categorized as a trace element because it is only found in about less than 0.01% of our body weight. And it is an important micronutrient because it serves a very integral function as a component of thyroid hormone. Despite the fact that it is only found in very minute amounts in the body and with the abundant sources in food, because of socioeconomic and geopolitical reasons, we still see a significant number of patients with iodine deficiency, both children and adults. Children are actually especially susceptible to trace element deficiency in general because of these three factors. One, growth creates an increased demand for most trace elements. Number two, some organs are more likely to sustain permanent damage because of trace element deficiency during childhood. And third, because in children, especially in the developing world, they are more prone to gastrointestinal disorders that can cause trace element deficiencies primarily because of malabsorption. So iodine deficiency, together with iron, zinc, and vitamin A, is the top priority of the World Health Organization as a concern in global health because it has detrimental effects in the overall health in the human population. Now, let us specifically talk about the neurodevelopmental outcomes of iodine deficiency. When we talk about neurodevelopmental outcomes in iodine deficiency, it actually revolves basically on two things, which is intellectual disability and delayed or brain growth retardation and development. So there are definite abnormalities that we see in iodine deficiency. Even with mild iodine deficiency, there is already a definite abnormality that you could see, such as delayed reaction time in psychomotor tasks. But more so, when you have moderate iodine deficiency, then you will have significant abnormalities in psychomotor and intellectual development in both children and adults. So as you can see in this slide, visual motor performances, motor skills, perceptual and neuromotor abilities, developmental quotients, and intellectual quotients are all affected with at least a moderate iron deficiency. But when you go into severe iron deficiency, then we now have the condition called cretinism, which is the most severe form of brain damage caused by iodine deficiency. Essentially, when we say cretinism, it is defined by severe and, take note, irreversible alterations in brain development, intellectual disability, and a combination of other neurologic manifestations. So cretinism has been described even as early as in the 18th century in Europe. And there are basically two types, the mixed edematous type and the neurological type. So when you see a neurological type of cretinism, you see the following manifestations, such as the patients are deaf-mute, they manifest with a squint, they also manifest with spastic diplegia, motor rigidity, and a shuffling or a festinating gait. In the mixed edematous type, you also see dwarfism, of course, mixed edema, and sexual immaturity. So all of these are signs of severe thyroid insufficiency in cretinism. Let us briefly talk about iodine and brain development. This was elucidated already by the previous speaker very well. So I would just like to reiterate some points. First of all, just like what I've said a while ago, iodine is a very important micronutrient because it is required for the synthesis of thyroid hormone. And in turn, thyroid hormones are required for brain development, which occurs during fetal and early postnatal life. So thyroid hormones are involved mainly in neuronal migration and terminal differentiation of neurons and glia. And this occurs very early on during pregnancy. Neuronal migration in the cerebral cortex is actually extremely sensitive to thyroid hormones, and even minor deficiencies of iodine can lead to possible defects in neuronal migration. Which is why, as emphasized previously, maternal hypothyroxemia during early pregnancy is a key factor in the development of the neurologic damage in severe iron deficiency in the child. There have been a lot of studies which show that certain areas in the brain actually have the highest iodine levels, particularly the frontal cortex, the caudate nucleus, and the putamen. Interestingly, these are the parts of the brain which subserves cognitive function. And in cases of iodine deficiency, there are certain structures which are particularly affected, as well as certain brain systems which are affected due to iodine deficiency, such as the hippocampus, which subserves a very important function because it integrates certain information for integration into memory, both short-term and into long-term memory. Myelin is also affected, and we all know that myelin is actually a very important protective substance in the axon, and it will result to either a dysmyelinating or a demyelinating effect if you have iodine deficiency. And of course, neurotransmitters are also affected in iodine deficiency. Because of these neurodevelopmental outcomes, as evident in patients with iron deficiency, there has been a global effort to address this particular global health problem. Thus, the World Health Organization has emphasized that we should develop strong commitment from the public health authorities and education of the public regarding iodine deficiency and how to address iodine deficiency. We should also emphasize effective collaboration with all partners involved, especially the salt industry, as evidence has showed that fortification of salt with iodine actually effectively decreases the incidence of iodine deficiency in certain populations. And there should be a good monitoring system to make sure that salt is adequately iodized, and national legislations on iodized salt should be enforced. So that would be the end of my talk. So these are my references. So thank you very much for this opportunity.
Thank you, Dr. Solis, for your presentation. Is it true? It is true that once a child is born, iodine continues to play an integral role in the growth and development of our children. Hence the importance of alleviating iodine deficiency as mentioned by Dr. Solis. We now open the forum for your questions as we have our local speakers with us, Dr. Carmela Madrigal-D, Dr. Cynthia Feliciano, and Dr. Adolfo Solis. Again, you may use the chat box and type in your questions, and please address your questions to the speaker so that we can line them up. And you may also raise your hand if you want to be recognized before speaking. Okay, so do we have questions in the chat box? Let me see. Okay, so we have one question here for Dr. D. Do obstetricians, ma'am, conduct screening for iodine deficiency in terms of the urine concentration of iodine among your pregnant women during their prenatal checkups po?
Thank you, doctor, for the question. We do not routinely screen for iodine levels in the pregnancy. We go by the symptoms pa din. So what I mentioned a while ago, doctor, and sorry, very sorry for the slide malfunction. What I mentioned earlier was we really go by the risk, by looking at the patients who are at risk, and then that's who we screen with the thyroid hormone level with TSH, FT3 and FT4. But we don't until today we do not do universal screening for pregnant women.
Yes, ma'am. And as a follow-up po, do you routinely advise or prescribe supplementation of iodine to your pregnant women or your patients during their prenatal checkup or even before during their counseling for before conception?
Actually, doctor, we do give them iodine supplements, but I think yan din ang isang na-overlook nga natin. That's why this is a good venue for all of us obstetricians, and also one of the campaigns, of course, that we should do to make sure that we give iodine supplementation. Kasi what normally happens is yun nga na if you do not see any symptoms, we do not routinely check the iodine level. So we do not know the iodine level of the patient. So cannot give supplements if kulang. So dapat po talaga we really have to check iodine level if we find the need for it. And yes, we will give them supplements when we see that they are inadequate in iodine.
Thank you, ma'am.
Thank
So
you.
still it's a case-to-case basis po,
Yes,
no?
it's on a
So yes.
case-to-case basis.
Okay po. Thank you, ma'am.
Targeted pa rin sa patients who really need to. Thank you.
Thank you po. And we have a question here for Dr. Feliciano. Hi, ma'am. Ma'am, do you think that the present system for screening for specifically for congenital hypothyroidism is effective? And are we detecting the condition in our babies? Kumbaga, is it enough?
You mean the newborn screening?
Yes, ma'am. The newborn screening, is it enough for in your perspective po? And if not, what are the areas for improvement such that we can achieve that 100% coverage of newborn screening for our Filipino babies?
Yes, as I have said a while ago in my slide presentation, there are two perspectives. When it comes to the detection of the disease itself, the TSH screening included in the newborn screening, or what was being done in the newborn screening, is precisely okay for us to detect the condition. But as to the national coverage, we have reached as far as 93% last 2019, but this time it's only 80.4 this 2020. So what we are missing out is about 10 to 20%. And who are among these infants who we have missed? And these are the ones who are, let's say, not hospital born outside the hospital, or living those in the far-flung areas. So what we can do probably is to try to achieve this 100% coverage. For example, increasing the budget for tracing these babies or infants who are living far from our centers, wherein we have the newborn screening, or where we do our newborn screening procedures. That's one. And then we have also cases, for example, as one presented in the slide, the missed cases, the 5% in terms of contamination and failure for some form of problems with collection. We have to again retrain our staff or personnel in charge of the newborn screening to have revise or refine their collection to be able not to miss out those babies who may be having the congenital hypothyroidism. So it's more of a collaboration with, let's say, of course, our government that we really have to put into so as not to miss out the, let's say last year, we missed out 123 babies who are supposed to be congenital hypothyroid. So budget, of course, and more manpower perhaps to be able to reach out to those who cannot come or access our centers for the procedure. I think that's it.
Yes, thank you. Thank you, ma'am. We have a question here for Dr. Solis from a Zoom participant from abroad. Are patients with cretinism, especially cretin nervosa, also deficient in micronutrients? And how do we assess them clinically or in terms of laboratory tests, sir?
Definitely for cretinism or cretin nervosa, there are a significant portion of patients which are also deficient in other micronutrients. That's why the role of proper nutrition in the rehabilitation of patients with iodine deficiency is paramount. You also have to take care of well-balanced nutrition for these particular patients as part of your treatment regimen. And of course, as far as clinical evaluation is concerned, you have to watch out for subtle manifestations of iodine deficiency, especially in growth and development or developmental delay. Subtle manifestations of developmental delay is very important to detect because usually, if the neurological manifestations of cretinism are already full-blown, then the effects in the brain is already irreversible. So the early detection of the subtle manifestations, especially developmental delay, is a must for physicians. Perhaps you could also, as far as laboratory test, perhaps you would like to make a baseline test for thyroid function or perhaps a thyroid scan, just to eliminate other differential diagnosis for the iodine deficiency of the patient.
Thank you, Dr. Solis. Okay, so I think that's all the questions that were forwarded through Zoom and other channels. And we will now conclude the question and answer portion. Thank you very much for our participants for sending in your questions. And at this juncture, since we have reached near the end of our today's session, we would like to call Dr. Clarito Cairo Jr., Medical Officer 4 of the Cancer Control Division, to present the certificates of appreciation to our speakers. Over to you, Dr. Cairo.
Thank you, Arnel. Good afternoon, everyone. So the Department of Health awards the Certificate of Appreciation to Dr. Carmela Madrigal D. in grateful appreciation of her invaluable contribution as our distinguished resource speaker on looking beyond the usual obstetrical needs of the pregnant women on May 26, 2021, during the week-long virtual observance of International Thyroid Awareness Week and World Thyroid Day from May 24 to 29, 2021. Signed by Dr. Maria Rosario Vergere, our Undersecretary of Health, Public Health Services Team, Department of Health. Thank you very much, Dr. Madrigal D.
Thank you very much.
The same
Doctor.
certificate is awarded to Dr. Cynthia Feliciano for her talk on newborn screening for congenital hypothyroidism. Have we picked them up? Thank you very much, Dr. Feliciano.
Thank you, Doctor.
The same certificate is awarded to Dr. Tim Corivar for his talk on clinical studies on the association of maternal iodine status, thyroid function, and fetal brain development. Thank you very much, Dr. Corivar. And lastly, the same certificate is awarded to Dr. Adolfo Solis for his talk on neurodevelopmental outcomes in iodine deficiency. Thank you very much, Dr. Solis. Over to you, Arnel.
Thank you, Dr. Cairo, and thank you to our guest speakers, especially to all our participants for joining us in this third day of the webinar series. And now let us just have a quick photo documentation. May we request everyone to kindly open your video cameras, and Miss Dolly, kindly take the photos, please.
Yes, good afternoon. So kindly keep your cameras open. So as seen on this slides, we have a total of 8. So I'll take the first slide. Keep your cameras open. 1, 2, 3. So next one. 1, 2, 3. Smile. You're on the third slide. And then the fourth one. Fifth. Sixth. And seventh. Okay, all done na po, Doc Pauco. Over to you.
Thank you, Ma'am Dali. Thank you, everyone. And now let us give you a glimpse of what to expect during our fourth day of this webinar series. As you can see on your screens, we will have distinguished speakers from various specialty societies and another speaker from the Department of Health or from the Department of Education, rather, to discuss with us the impact of thyroid disorder in the school and workplace. Okay, and then we hope that we will see you again tomorrow and join us again as we continue to celebrate the International Thyroid Awareness Week. Kindly register using the same link and scan the QR code being flashed on your screen now. And as we invite everyone to also take the survey that is being flashed now on your screen, so that you can help us further improve our learning sessions by giving us feedback through this link and scanning the QR code. Your certificates of attendance will be sent via your email upon completion of the survey forms. And thank you once again. Have a great day ahead, and please stay safe. Thank you.